So as Kat said, I'm a retrieval consultant for SAS MedStar, which is the retrieval service for South Australia. So I work as a ED consultant as my base specialty, and then I'm a medical retrieval consultant and work clinically and coordinate for SAS MedStar and have a management position as well, which is obviously quite busy. And work with lovely Amy and Mardy, which is great. I'm just going to start off with a little example of the sort of things we end up doing. So as I like to imagine, you're woken up on a Monday morning and you're really excited to go to work. You're the coordinating consultant for the retrieval service, and you're on call from 6 a.m. So at 6:15, your very grateful night colleague has phoned you to tell you about all the outstanding work there is. And that is both retrieval work and into-hospital transfer work. So they've told you all that, and you think, well, I may as well get up and go to work now, as I'm awake, and the kids need breakfast, so off I go. Good time to leave. So get in the car and start the drive to work. And on the way, one of the nurse retrieval coordinators calls you to say that there is a child in a small town who's it's about 3 hours drive, maybe a little more, about an hour helicopter ride. And this child's been unwell with a virus. They're 4 years old, and they're not too bad from a viral point of view, but their parents brought them in because they're just not eating or drinking very well. And they've done a blood sugar and it's 20, and their ketones are 6. So that's all the information you've got, but obviously presuming that this is a first presentation diabetes and the child's in DKA. So, okay, it's difficult to get a bit of a handle on what this child looks like, but you are thinking, well, I'm on my way in, I'll have a look at them on telehealth and we'll make a plan because this child's clearly moving. Need to get a retrieval team to them. And then unfortunately you put the phone down and carry on driving with your phone on speakerphone, obviously. And you get another call about 3 minutes later saying that there's now a child with critical asthma. And they're in a hospital about 8 hours drive from Adelaide or an hour's fixed wing flight. And there's no doctor in the hospital. So they're in a very small hospital with 2 sensible nurses. And you're told that they've had salbutamol all night, they're now critically unwell, they're drowsy. So you think, again, fairly easy call. Better send a retrieval team to that one as well. But if I then say, take you back to the rest of the story, that's the simple answer, isn't it? Is that we're going to send a retrieval team to both of these children. They're both probably critically unwell, and that's easy. So this is the area we work out of in coordination. So MedStar is the retrieval service that sits within the South Australian Ambulance Service. So we work on base for our clinical shifts down near the airport, which is obviously near RFDS and Babcock, who provide our transport and more. But we coordinate from the ambulance headquarters. And this is the room that we coordinate from. So there's not usually that many people in there, unfortunately. And so we have 2 to 3 nurses coordinating there who take all of the phone calls and coordinate our inter-hospital transfers and help us coordinate the retrievals. And we obviously support them in both of those as well as the consultant. So this room can take up to 400 or 500 phone calls a day between 3 nurses at the busiest times, 4 if you're very lucky. Average 4 or 5 retrieval requests a day, but that can be easily 3 times that on a bad day, and up to 40 to 50 requests for patient movement across the state, which, as you'll find out in a moment, is a problem. So we monitor all the transfers out of there, and we assess them. So the nurses will assess the patients. If they think it needs a retrieval, or they're not sure, or they want a bit more support, then they'll get the consultant on the phone as well, or ask their advice. Otherwise, they will process the inter-hospital work. We have the ability to do telehealth, which in this case was very useful. We have a couple of telehealth cameras, and we can use that to help assess. So the phone calls come into this room from all over the state, as you said. So there's about 70 different places that can refer us patients. And we cover a fair proportion of the state. Alice Springs cover some of APY lands, so we don't cover that bit. And then RFDS Commonwealth cover sort of patches in between as well of some of the more remote places. So you've got into the office and you have decided that you're going to look at these children on telehealth. So which one first? You've got 2 children who are apparently both critically unwell. There's only one of you. Luckily, actually, I happened to be in the office that day, so we were very lucky that there were actually 2 of us. So we divided and conquered and took 1 each. And again, we said, well, it should be easy, is that we're going to send 1 pediatric team in a helicopter to the first child, and the other pediatric team in a plane to the other one. That's easy, except the weather's really bad, so the helicopters can't fly, and both of the other morning planes are out on retrievals already, so there's only 1 plane available. And we could drive 8 hours, but I think that'll be a bit of above and beyond. So what are we going to do, and how do we make the decision of what to do from here? Well, luckily, as some children do, I had a look on telehealth at the asthmatic child, who in my head was probably going to be the most urgent, because DKA we can manage, we can support people through that. These are sensible regional clinicians who have the skills to do that, and they can manage the DKA while they're waiting. Whereas a critical asthma in hospital with no doctor, quite a long way from Adelaide, that's much more urgent. So in my head, I was thinking that's the one we're going to first. So got her up on telehealth, this very cute child, as they obviously all are, which is lucky. I can see why people want to be pediatricians, because they're much cuter than adults. And I looked at this child who I agreed looked pretty unwell. She was sort of floppy and drowsy and a little bit pale. And we had a chat, so the nurses and I had a chat, and we talked through it, and thought that actually probably she wasn't as bad as she looked. Which was a quite difficult decision to make, but helped significantly by being able to see her on telehealth. And as with many children, I've noticed, fixed her with a Zupa Duper and a nap, which was great. And that was quite obviously reassuring, because I was a little bit worried about what the poor nurses were going to do. Luckily also, their doctor arrived from the next town at the same time, very sensible regional GP, and agreed entirely, phoned back in an hour later, and the child looked really, really well after a Zupa Duper and a nap. And we moved her to a smaller regional centre. And that was really lucky, because obviously if we haven't been able to do that, then we're still in that what do you do? And in the meantime, my colleague was on telehealth with the other centre, who couldn't get IV access. They were really, really struggling with this child who was becoming sort of increasingly tachycardic. GCS now 14, not looking fantastic. Managed to get an IO in to this brave little thing, and started giving some fluid, which is obviously great. Still don't really know what her gas is like, which is obviously quite disconcerting, especially for my colleague, who's an ICU consultant and is not used to working with no information whatsoever apart from a blood sugar of 20 and a ketones of 6. I'm ED, so obviously I'm like, it is what it is. What can you do? So, and then, plus I feel terrible even saying this, they managed to get another doctor in, and this stoic 4-year-old tolerated having a line put in her neck. Just an IV line, but still, I think I would have been cranky if I was that child, which is probably a reflection that she was actually quite unwell. But that took about an hour and a half to get that line in from when we first spoke to them. And in the meantime, what do we do? So we've got this child who we think probably needs fluid. Obviously, that's fairly easy, giving her fluid. But do we start an insulin infusion after that hour? What's her potassium? How do we know? How are we going to support them through this? Because if we start fluids with potassium, then if she's in renal failure, unlikely, I know, but if she's hyperkalemic, we're going to cause harm. If we start the insulin and the potassium is normal, and don't start potassium, then we're obviously in trouble as well. And all we have is one IO, so you've only got one thing to run until they got this line in. And then we established that actually she was, unsurprisingly, very acidotic and hypokalemic, and could start treatment for both of those things. But in that time, from the time of that call to the time we can get a team to there, particularly fixed wing, because obviously you've got the road legs as well, that's going to be sort of 2.5 hours probably before we can get someone to that child. So although the decision obviously to retrieve is quite easy, in the meantime, we've got to support that team through a couple of hours of managing this child, which they're completely able to do. They're sensible regional clinicians, again, rural generalists who can manage that, but they're also trying to look after the whole of the rest of the hospital, multiple other patients that they've been handed over this morning, and they're obviously asking, why are you not here yet? Please, can you come and help us? And this child's actually looking increasingly unwell. Luckily, obviously, with two of us to divide and conquer, my colleague managed to interpret the local guidelines, which, when we went through them, turned out to be more difficult doing maths than it should be. But we hadn't had coffee at that point, so I think that is probably why. And worked out the calculations, and then scrolled down to the bottom where it tells you the weight-based totals, and we could have just done that, but anyway, never mind. Helps when you read to the bottom of page 32. So we managed to support them through that, and that was great, and got a team going. And this child was, in fact, quite unwell. The first child with the asthma, all good, no worries at all. So now it's 8:30 in the morning, and you've got a whole day ahead of you of retrieval to work with. So, as I said, we're still covering all of this. So, as I said, we have quite limited resourcing, and I think that's where really the problem is, because if we had 10 pediatric retrieval teams and 10 general retrieval teams and 15 planes and 7 helicopters which can actually fly in the rain, or if it's too hot or if it's too cold, then it would be easy, wouldn't it? Because every call you get, you can just send a team. But we don't. We're working within a really, really tight resourcing setting. So we have 3 planes, 2 helicopters available to us, and 2 general teams and 2 pediatric teams, 24/7. And with that, we have to manage those 50 requests for patient movement throughout the state. And some of the states are quite big, as you probably know if you live in South Australia. So if we're going up to Cooper PD, that's a couple of hours flight. If we're going out to Ceduna, that's a couple of hours flight. And obviously, there's some really unwell patients out there that we need to try and help with. And particularly with pediatrics, as you know, there's a lot of nervousness around kids. You know yourselves, is that even the most comfortable person, sometimes children will freak you out, and sometimes they pretend they're just fine, and then they're secretly not. And that can throw you off. Or sometimes they pretend they're really sick, as their critical asthma child, and actually they just need a super duper. So it can be really, really difficult. And we use telehealth a lot with these children because a picture paints 1,000 words. So that makes it easier for us. But that doesn't make it easier for the regional clinician to actually look after that child in the meantime, or to make their assessment in the first place. And they have to obviously balance that among all the other patients that they're looking after. And so sometimes we will support them during that time. And we seek help. So I'm work in a mixed ED. I'm sort of mid-level comfortable with children. Some of my colleagues don't, and they would seek help from pediatric colleagues or from the pediatric intensive care consultants. So we'll bring in help there when we need it. But ultimately, we're trying to balance these children with the other multiple requests for retrieval across the state and the planes we want to send to get to other sick people. And some of them are not critically unwell, but they are time critical, and some of them are not time critical, but they are critically unwell, and some of them just need to get to Adelaide to have their hip fixed, and that's fine. So that's a really, really difficult balance for us, and our job really is to manage and hold that risk for the state, and work out what we can do to try and do the most for the most people, and try and make the right decision. So we luckily have gone away from 24-hour shifts, because as you can imagine, getting a phone call every 20 minutes for 24 hours is quite a challenge. And now we just do it for 10 hours or 12 hours, at a time, and that's much nicer. But it can be actually really, really fatiguing making decisions and holding that risk in your head, and also sort of like playing chess or moving deck chairs on the Titanic of who can manage what. And the way we use the information we have is that obviously we're all experienced retrievalists, and we have backup and support to give us advice if we're not sure. But we hold in our head of those 70 referring centres, what can they do there? So, for example, Mount Gambier down in the southeast, reasonable hospital. It's got some really experienced people. They've got anaesthetists, they've got FACEMs, they've got paediatricians, they've got sort of HDU level care, and they can manage some pretty sick people for a while, which is lucky because about 2 a.m. every winter night, the fog rolls in, and you can't get into Mount Gambier for about 6 or 7 hours. So that's kind of important to know when you're assessing a child at midnight in Mount Gambier, is that you may well not be able to get them, unless it's summer, and then it's fine. Whereas out at Ceduna, for example, again, they have there's some patients coming in from community who are quite high risk. They have some really unwell patients there. But there's a GP anaesthetist who's very good. Sometimes they have obstetrics and have more hands on deck. But that's a very, very small town. No radiology, very limited labs. So obviously my risk assessment for them is entirely different to Mount Gambier. And that can be true around the state. We're really in a slightly different situation in Adelaide, in South Australia, in that we have everything's very concentrated metropolitan. So we don't really have any big, really comfortable regional centres who will manage to the level that somewhere like New South Wales or Victoria has. But that just makes it more interesting, I suppose, for us, and probably slightly more nerve-wracking for the people working out there or living out there. So that's essentially my job and my day. We would combine, as I said, those two children with another 6, 7, 8, 9 requests for retrieval from people varying from really, really unwell to sort of critical trauma. And we are quite unusual in that we cover, as a service, everything from birth or sort of preterm to death. As a general trained consultant, I manage from 1 month to geriatric, and obviously seek help for the 1-month-olds because they're not my comfort zone. And then we have neonatologists, such as Amy, who coordinate the smaller babies, who obviously like alien species to the rest of us. So we're very grateful for that. But that's a massive, diverse group of people. It's a massive number of people who need to be moved. And we all come from very different backgrounds, as I said, anesthetics, ICU, ED, and we all try and keep that skill set of managing all of those patients in all of those places and knowing what each of those can do so we can really triage to the best of our ability. And I'd like to think that we do it fairly well most of the time, but it's quite a stressful and challenging job, and can be quite difficult making those decisions with very limited information sometimes. Thank you.